Well, hello, everybody. Good afternoon or good morning, depending on where you are in the country. My name is Garrett Schmidt, and I'm the managing editor for VBC Exhibit Hall. And I'd like to welcome you all to today's live webinar hosted by Health Data Analytics Institute, or HDAI, and with special guests with Remo Health. And it is titled The Beyond Guide, how data-driven strategies are paving the path for better dementia care. And this is a topic that doesn't get as much attention as it should. So I'm glad you all joined today because we're going to cover some very important information, and I think you'll enjoy the presentation. A few items of note before we get started. All the listeners have joined today in listen-only mode, and so you don't have to worry about muting your microphone or turning off your camera. This is a traditional webinar format. Secondly, the session is being recorded. So when we're done, you will receive an email maybe an hour or so after we conclude, and there'll be a link to the recording and also to where you can download the slides from today's session, so that you can review it, you can share it with colleagues and friends, and we hope that you do. And then finally, without further, oh, actually, one more thing is we are going to have a time for Q&A towards the end, and would love to hear from you. If you have any questions at all during the presentation, go ahead and drop those questions into your mod. You have a little module there as an attendee, and there's a place for questions. So go ahead and submit those. We're going to get to as many as we can during the allotted time today. If we don't get to yours for some reason, don't worry, someone will reach out via email afterwards and to make sure that we get your question answered. So without further ado, I would like to briefly introduce our speakers today. We have Dr. Meredith Brock, and she's the Chief Medical Officer at Remo Health. And we have Dr. Scott Greenwald, and he is the Chief Scientist and VP of Research at HDAI. So, and I believe Dr. Brock is going to get us kicked off. So welcome.
Thank you so much, Garrett. It's great to be here today. I'm Dr. Meredith Bach, a neurologist, researcher, and Chief Medical Officer of Remo Health. My mission in life is to improve quality of life for people with neurologic illness and their families, which is what brought me to Remo. Remo's purpose is to leverage technology to deliver virtual, accessible, and comprehensive dementia care to people with dementia and their care partners across the full disease journey. Our virtual care model is grounded in evidence, enabled by technology, and delivered with empathy. Truly, my two favorite things to talk about in the world are dementia care and data. So I'm so excited to be here in conversation with you, Scott.
Excellent, Meredith. Yeah, I'm Scott. I'm a medical engineer and a scientist by training, and I serve as chief scientist here at HDI. So HDI specializes in healthcare data analytics that are specifically designed to reveal insights for hospital systems, ACOs, and research collaborators. We provide offline comparative outcomes analysis like those that we'll describe today with Remo, as well as a real-time intelligent health management system that we call Health Vision. Health Vision is an AI-powered suite of applications which drives personalized care planning and population health improvements. So Meredith, to get us started, could you talk a little bit about what dementia care looks like today?
Absolutely. Dementia is a major public health issue in the United States today. With the aging of the population, the number of people with dementia is rising rapidly, and we're expecting to see almost 15 million people with dementia by the middle of the century. Alzheimer's disease is the only major cause of death where we've seen an increase in the death rate in recent years compared to decreasing rates of other chronic conditions such as heart disease, cancer, and stroke. This is the sentinel healthcare challenge of our generation. So in current standard of care, which I can tell you about from the front lines of being a neurologist, there's a huge lack of proactive cognitive screening and diagnosis, with only 16% of older adults undergoing regular cognitive screening. The majority of primary care doctors report that they lack the time or the specialty expertise to diagnose or manage dementia. Diagnosis is usually delayed or doesn't happen at all. About half of cases of dementia are never formally diagnosed. This prevents people with dementia from being connected with treatments that can delay disease progression or improve symptoms. And importantly, there's a huge lack of care partner support, care coordination, or connection to community resources to address the wide range of medical and non-medical needs that come with a dementia diagnosis.
Yeah, In addition to the PCPs being reluctant to diagnose or manage the dementia, I believe many aging individuals are reluctant to seek help when they experience cognitive decline for the obvious fear that the cause of their decline might be some chronic disease. Now, while that fear is probably realized for many individuals, delaying diagnosis in either case is typically a bad move, as it just delays the opportunity to intervene to improve the symptoms or slow progression of the disease, as you pointed out. I believe that your work dovetails very nicely with the objectives of a broader government national plan to address Alzheimer's disease. This plan is a multi-year plan, and it includes the goal of enhancing public awareness of dementia, including specifically the benefits of early detection and diagnosis. And because of those efforts, I'm increasingly hopeful that the improvements in education of our general population about the benefits of the early treatment will mitigate anxiety and thus encourage the elderly to go seek help early on so they can get the benefit. Ultimately, either way, patients will either seek out help proactively or reactively if they have a complication from dementia. So Meredith, what associations are you observing between dementia patients and healthcare utilization?
Yeah, well, firstly, I couldn't agree more with what you just said, Scott. Improvements in education and public awareness about screening for cognitive decline are so important, and we want to be ready on the other end to provide those services when people appropriately seek them out.
Mhm.
So, a large body of literature shows that dementia leads to increased utilization of healthcare, leading to over 3 times the cost compared to people without dementia. Many of these expensive contact points with the healthcare system, such as emergency room visits or hospitalizations, are from potentially preventable causes. So the key, so there are several key drivers of these adverse outcomes in dementia. One is the use of high risk, potentially inappropriate medications, such as anticholinergics and benzodiazepines. In many cases, these medications are prescribed for urinary symptoms or mood or sleep, and the prescribing provider may not know that they can worsen cognition, function, and balance. Falls are a very common cause of hospitalization in dementia, many of which could be prevented with interventions in the home, physical therapy, or changes to the medication list. Caregiver burnout and depression is also a key modifiable and overlooked risk factor for healthcare utilization. A really important paper analyzing data from the UCSF Care Ecosystem Study showed that the presence of caregiver depression predicted increased emergency healthcare utilization in people with dementia. So, evidence coming out of the UCSF Care ecosystem and similar programs demonstrate that team based dementia care can avoid adverse and costly outcomes for people with dementia. This robust body of evidence is the foundation of an exciting new payment model for or for Medicare beneficiaries called Guiding an Improved Dementia Experience, or GUIDE. This new 8-year pilot model will provide a per patient per month reimbursement to organizations providing dementia care who fulfill key requirements, including a provider with memory care expertise, a multidisciplinary team of experts in dementia, support for family caregivers, including education and training, connection to the right community based resources like respite services for caregivers, and 24/7 access to the care team. The purpose of this model is to provide the care that we know works. At this point, there is the highest quality evidence, randomized clinical trials run at top academic centers such as UCSF and UCLA, showing that these team based dementia care models reduce caregiver burden, increase patient quality of life, and reduce healthcare utilization. Most people want to stay living safely in their homes for as long as possible. So, GUIDE will also test whether this care will enable people to prevent or delay admission to long term care. This would help both fulfill the wishes of families who want more support at home and reduce one of CMS's biggest expenditures, which is long term care.
Well, thank you. Clearly, I see a number of significant gaps between the current and ideal dementia care, both for the dementia patients, but also for their caregivers. It's encouraging that the GUIDE program is now available and will help finance some of these key improvements. The task now at hand is identifying those individuals and institutions where the help is most needed, particularly in underserved communities, and this is where HDI helped. To help meet RUMO's objectives, HDI set out to quantify the absolute and relative needs of the patients throughout the entire nation for dementia diagnosis and intervention. The results that come out from this analysis will reveal those regions, institutions, and practices that have the greatest needs. The approach that we took was to conduct a comparative outcomes analysis using the CMS Medicare database. HDI has privileged access to the entire CMS database, which provides complete longitudinal records of patient utilization of inpatient, outpatient, skilled nursing, home health, office, and hospice resources. These claim records provide detailed past medical history per patient, including their medical status, the interventions they received, medications, and costs. We utilize this resource in two ways. First, long prior to this project, we had developed hundreds of predictive models using methodology which we have published. Because these models identify drivers of risk for a given individual, providers and care teams typically use this information to identify and work up the riskiest patients in an effort, obviously, to reduce the adverse events and cost. Second, we can use the database to benchmark every provider, hospital, or an organization so that we might help them understand their performance without ever needing any data from them. In this project, we focus on providing results for regions such as counties, as well as institutions such as home health agencies. To derive the outcomes for a given cohort relative to the nation, for a county, for example, we matched each patient in the county to all similar patients throughout the nation using what we call digital twinning. This method tightly matches patients to control for differences in demographic, institutional, and regional characteristics. Most importantly, when we examine relative outcomes for adverse events, utilization, and costs, we additionally match patients on the predicted risk of the outcome that we are analyzing using our prediction models. This process of matching patients provides risk-adjusted comparative results. That is, the matched analysis provides three metrics per endpoint. That is the results for the cohort of interest, which we call the actuals, the results for the matched patients, which we call the expected results, and the all-important ratio of the actual to expected, or ADE, which provides the relative risk-adjusted results. Thus, regions having either high or low ADE, depending on which metric you're looking at, are those having the greatest needs for that endpoint. For this analysis, we had utilized all Medicare fee-for-service beneficiaries from 2018 through Q3 of 2023 that had criteria consistent with the guide requirements. That is, they had dementia, were enrolled in Medicare's Part A and B, but were not enrolled in Medicare Advantage, nor were they in a special need program such as PACE or in long-term nursing home or had entered hospice. So as you can see on the slide as tabulated, there are a number of endpoints that we studied in this analysis, and I will highlight just a few. We calculated the absolute and relative total cost for the dementia beneficiaries. In addition, we provided results by spend subcategory, that is for inpatient, outpatient, care, home health, and skilled nursing utilization. To help assess the drivers of those costs, we also provided the absolute and relative rates of utilization of these services, for example, inpatient and ER utilization, and we report those in visits per 1,000 beneficiaries. In combination with the results with other endpoints, these metrics helped REMO identify where they might be able to impact avoidable healthcare utilization and the associated costs.
So using the methods that Scott described, there were really two key questions that HDAI helped us at REMO answer. The first was, where is the need for our dementia care management services the greatest? By understanding prevalence of dementia and utilization within each county, We were able to understand where there was unmet need for care. The social deprivation index, demographics, and number of providers also informed our approach to reaching high need, currently underserved populations, making sure we fulfill our mission to improve health equity. We even went one step further, more granular, in understanding where people with dementia are living with risk factors for preventable adverse outcomes by leveraging the pharmacy data and looking at the proportion of high risk medication use by geographic region, which I can attest was very high. We found in these data that people with dementia, over 70% of them were prescribed an inappropriate medication of an anticholinergic. The second question that HDAI helped us answer was, where is the need for our dementia care diagnostic services the greatest? In other words, where are people with likely undiagnosed cognitive disorders living? This is obviously a more difficult question to answer as they are undiagnosed, but we used established risk factors for undiagnosed dementia, such as comorbidities and certain patterns of care utilization, to understand the number of people at high risk for undiagnosed cognitive disorders by region. These approaches were obviously helpful for guide and beyond guide in informing other strategic decisions. So why does answering this second question matter? On average, dementia is underdiagnosed by half. Earlier cognitive disorders are even more rarely diagnosed, with only 8% of cases of mild cognitive impairment identified. An accurate or timely diagnosis of dementia is impactful for several reasons. First, a neurologic evaluation enables the person to be evaluated for any reversible causes of cognitive decline, such as metabolic or mood issues that are treatable. Second, if a neurodegenerative condition such as Alzheimer's is truly the cause, then it's really important for people to receive the information about this chronic, progressive, currently incurable condition and what it means for their future. Doing advanced care planning, identifying a proxy healthcare decision maker, and other crucial conversations about the future need to occur early in the disease course when the person has the capacity to participate in decision making. Third, an accurate diagnosis enables the person to get on appropriate treatment. While there's no cure for dementia, there are oral medications and now novel anti-amyloid infusions for Alzheimer's that can slow the progression of disease in certain people, but only if they receive a diagnosis early enough in the disease course. And lastly, it allows the team to take action to prevent the adverse outcomes we spoke about that we know people with dementia are at risk for, and get the caregiver the right training and support to prevent depression and burnout and ultimately lower costs.
Hmm. Well, this brings us to the question of how HDI could help REMO in promoting health equity in dementia care. Because our hope was to identify the regions with the greatest needs, we needed to utilize composite metrics of social determinants of health, like the Area Deprivation Index or the Social Deprivation Index that I'll describe on the next slide. The Social Deprivation Index was developed to quantify the disadvantage level of communities as it relates specifically to healthcare access and to health outcomes. The SDI is a composite measure of 7 demographic characteristics collected by the American Community Survey as listed on the slide. The SDI ranges from 1 to 100, with higher values indicating worse deprivation. So those red regions that you see on the chart there are those that are particularly deprived of access to healthcare in general. Now, by reporting the absolute value of the deprivation index per county, REMO could identify the areas that historically have been underserved. And by matching patients on their county's deprivation index, then the comparative analysis results would highlight those communities that were particularly underserved for the dementia community, even after controlling for the absolute level of deprivation. So one of the exciting parts of REMO's digital health, in my opinion, is that it's delivering comprehensive care to patients wherever they are, which helps close the gap in care in rural communities, which particularly are underserved historically and have not had access to quality, affordable health care. So Meredith, why don't you please tell us a bit more about how REMO is promoting health equity in dementia care and how the data analysis that we provided is allowing you to effectively do this.
Yeah, absolutely. So Remo's purpose is to deliver virtual, accessible, and comprehensive dementia care to dyads across the disease journey. It's closely linked to our technology objective to build a true learning healthcare system for dementia, so we can measure outcomes and ultimately achieve our mission to improve the standard of dementia care everywhere. Our interdisciplinary team includes a neurologist, such as myself, a care navigator, social worker, pharmacist, and RNs to meet the wide range of needs that dyads have across the disease course. All these services are provided through the central hub of the care navigator, who builds rapport with the caregiver over time, provides care coordination, responsibility we know typically falls to caregivers and increases their burden, and connects them to relevant community based resources. They also have access to 24/7 triage lines staffed by RNs to address the issues that arise at any time of day or night. We know that dementia is a 24/7 problem. You don't stop having dementia overnight. And so when issues arise at any time, they can call in so that RNs can help triage whether something is an emergency, whether it can wait for an urgent appointment in the morning, or whether it can be resolved on the phone. One reason we're so excited about the virtual telemedicine model is it, as you said, Scott, enables us to reach the communities that are not served well by the healthcare system, which we can identify through these data-driven approaches. In my prior brick and mortar clinic, I used to see people who drove from 8 hours to San Francisco
Mm.
from the California-Oregon border to my clinic for a 30-minute appointment and then back again. And many of their neighbors who needed similar care were not able to make that trip. For people with low access to neurologic care, telemedicine is an opportunity to bring the care to them. And it also helps us reach people in the more advanced stages of the disease who may have reduced mobility or they're completely bedbound and they have a lot of difficulty coming into clinic. These are the people who are usually lost to follow up, who we can continue to follow using telemedicine.
That's quite encouraging, Meredith. Remo's approach to reaching the needs of dementia patients sounds very hopeful. So, what are some of your plans now to address the unmet needs for those that are helping the patients?
Yeah, great question. So our clinical care is anchored in a caregiver support platform with two components. Learn is an on-demand library of medically reviewed guidance on dementia in the form of audio and articles. And Community is a HIPAA-compliant moderated forum where caregivers can connect with other caregivers or ask questions of our team of experts.
All right, so let's shift the conversation now and talk about some studies and pilot programs that have already demonstrated results and the benefit of comprehensive dementia care.
Great. So there have now been several randomized clinical trials run to look at the impact of these collaborative dementia care models. So the UCSF care ecosystem showed that a team-based dementia care program with care navigation led to less of a decline in patient quality of life and a greater reduction in caregiver depression and burden over 12 months. Caregiver self-efficacy scores increased more in the intervention group. It also reduced emergency room visits with a number needed to treat of 5 to prevent one ED visit. For people in the intervention, costs were reduced by about $6,000 per person per year. They also showed that there was greater cost saving in certain cohorts of patients, for example, those with more advanced disease or recent ER utilization at baseline, indicating that an even more targeted intervention could show greater savings. A similar study run at UCLA showed better quality of care and delayed admission to long-term care. And a study at Ochsner showed that a team-based dementia care model reduced costs by 31% or um, close to $6,000 per person per year. And while these studies all tested different flavors of the intervention, there were several common ingredients, including the interdisciplinary team, more comprehensive caregiver support, and individualization of care pathways. So in our own commercial pilot at Remo of our virtual care model in a value-based primary care setting, we saw significant reductions in ER visits, falls, and caregiver burden as measured by the Zarit assessment.
Well, Meredith, those results are certainly encouraging, and I'm hopeful that you'll be reporting improved outcomes due to the broader adoption of your technology, particularly now that you have some guidance from us on where to target those efforts. So as we've been discussing, HDAI's healthcare analytics have been successful in helping Remo in this example, and we've helped other organizations too. And I just want to share one other example. So this slide reports an example of improving outcomes for an ACO who wanted to reduce the escalating costs in utilization, particularly unplanned admissions. So prior to our collaboration, they had noticed that heart failure patients and patients with high RAS scores were frequently among those who had unplanned admissions. Their existing workflow was to share that list of patients with their providers and to request with the care team that they would follow up with the patients. Now, that approach was helpful, but it didn't satisfactorily reduce the unplanned admissions because it really didn't differentiate those patients that were likely to readmit from those who were stable. Once we began our collaboration, our approach was to identify all patients, regardless of the specific comorbidities, who were the most likely to readmit using our predictive unplanned admission model. In addition, we provided supportive information for these patients, including the specific predicted risk for the common causes of unplanned admission. That is for fall-related injuries, which are obviously important in dementia, for pneumonia, and for exacerbation of heart failure, which was common in their specific situation. And because of the constellation, rather based on the constellation of risks of mortality, hospice admission, and unplanned admission, we pooled patients into categories of care. Namely, we called them advanced illness, complex care, and rising risk. We call this classification SMART cohorts because it concisely categorizes patients based on multiple predicted risks based on their patient history and not simply on a single composite metric like RAF, nor on isolated comorbidities. These patient predictions were then used by the care management team to intervene to reduce the risk of these adverse events. Interventions included more frequent evaluation and management visits and enrolling patients into the appropriate programs, chronic care management, transition care, or remote patient monitoring as appropriate. Our capability to quantify risks associated with the utilization of services, adverse events, and costs enabled the ACO to prioritize their scarce resources, which resulted in having a significant impact on outcomes. As you can see, within 6 months of adoption, the ACO observed a 33% reduction in ED visits, a 22% reduction in unplanned admissions, and a notable reduction in cost. There are a number of other examples where we've helped collaborators improve outcomes, whether delivering what we call smart cohorts, as in this example, or by helping healthcare systems optimize their networks so that their providers can direct patients to higher quality facilities as appropriate. Meredith, there is obviously much more that we could present about paths to improving dementia care, but why don't we stop here and just open it up to questions from the audience?
Yeah, great idea. Happy to take any questions.
All right. Well, wonderful. Well, thank you both. This was obviously a deep topic. There's a lot here. And so if you have any questions for our speakers today, go ahead and drop that into, you have a module that's there just for questions. So go ahead and put that in there. We're going to get to as many as we can here. First question here in no particular order is what are the challenges of providing care by telemedicine to this population?
That's such a good question. I'm happy to take that one. So, telemedicine is an incredible opportunity to bring subspecialty memory care and a full team to people in their homes that in many cases they would not otherwise have access to. And I get this question frequently because I think we were all surprised that during the pandemic, I think we, even in the neurology community, were surprised by how well telemedicine works for many aspects of the neurologic exam. It doesn't work well for everything, but it's very well suited for the cognitive evaluation. So even many brick and mortar clinics have switched to doing many of their new patient evaluations by telemedicine because it's very effective. And so I think we were surprised by how well it works. We were certainly underutilizing it before. Um, and also, many people with cognitive disorders have engaged care partners who can help them connect to these appointments. Um, so I really think telemedicine is an incredible opportunity and really the way of the future. But this model also requires key on the ground partners who can do in home safety evaluations, in home labs, physical therapy, respite care. Many other things really do need to be done in person. So at Remo, we're building a robust ecosystem of high quality partners so that people get everything they need at the quality we expect. And part of what our care navigators do is help them with coordinating anything that is in person from a remote partner so they don't have to do that alone.
No, that's great. Thank you. Okay, next question here is at the beginning of the webinar, Scott mentioned something about a real-time system called Health Vision. Can you elaborate on that a little further?
Okay, absolutely. Yep. So Health Vision is what we call our intelligent health management system, which is powered by, in part, access to the CMS Medicare database. It consists of three critical elements. First, there's an intelligent health record that we call the patient spotlight. Spotlight summarizes information which we extract from both structured and unstructured notes in the EHR system and claim sources. It presents a summary health profile, simple to read and interpret, which also includes our risk predictions and the drivers associated with those risks. This allows the user to then also click on links to drive down to get additional information about why it is those risks are true, or what was in the clinical notes that indicated that information. The second point is the intelligent analytics solution. This is where we match your population to others outside your organization by accounting and do risk adjusting for baseline risks and other factors using the digital twinning methodology that I've already talked about. This allows you to benchmark your provider's mortality, hospitalizations, infection rates, and other key metrics of interest to you on an apples to apples comparison. And the results are very precise comparisons, which you can use then to help identify the strengths and opportunities in your health systems where you might want to improve outcomes. And then third, there's the intelligent workflow solution, right? We want to reduce the cognitive burden and the process burden that people have. Many hospitals have already health platforms or health workflows that they have, and we want to optimize what they're doing by identifying those individuals that would best benefit from intervention. So we provide them the smart cohorts and patient rosters, which allows them to align scarce clinical and administrative resources with the patients who would benefit the most. So if you're interested in learning more about Health Vision or our team's work, please do reach out and we'll be happy to walk you through your own data.
Wonderful. Yeah, that was a thorough explanation. Okay, next question here. And again, if you have a question, go ahead and drop it in now, using your little module there for the attendees. Next question is this: what do you think drives the cost savings from comprehensive dementia care models?
Hmm. Yeah, that's a great question. So the cost savings we talked about, which is from the existing literature between $5,000 and $6,000 per patient per year. So I think based on the existing research and my clinical practice, we talked about many of the possible causes, but high-risk medications, falls, care partner overwhelm, also lack of knowledge about how to manage behavioral symptoms of dementia can be a big driver of ED utilization. And I think these care models are all likely to reduce these. But interestingly, in the RCTs, many of the care models that have been studied are really bundle interventions. So I think there's a need for more research over longer periods of time with larger sample sizes, with pragmatic study designs that would really enable us to better disaggregate the effects of these bundle interventions and really see which specific elements move the needle on which outcomes for which types of patients in real world settings. So this is actually the cornerstone of our long-term research agenda at Remo. So hopefully we'll have more answers on this exact question actually in the future. And this is what will enable us to continually iterate on our care model.
Great. Okay, next question here is how are you identifying customers who are not yet diagnosed outside of assessing everyone? And the second part of that is, are there any data-driven analytics that support identification?
I can say one sentence on that or so. So using there are a number of predictors of dementia, whether or not somebody has dementia. So in the medical claims records, we know if they do because we use the Charleston comorbidity model to identify those that have dementia as quantified by that process. But there were two other predictors of or identifiers of likelihood that somebody has dementia. So we provided that information in addition to those that were classically diagnosed as dementia, so they would understand where the difference is between those that weren't diagnosed and those that likely had dementia from those that actually were diagnosed.
Yeah, great. Okay, next question here is thank you for your presentation. Did you include clinical pharmacists in your models of care?
Yeah, great question. So, um, in our commercial pilot, we did not have a pharmacist as part of the care team, and that was actually one of the biggest learnings from the pilot that um, the high-risk medication use and how that drove poor outcomes was so notable that in subsequent versions of our care model, we do have a pharmacist. And so we really feel that the clinical pharmacist is a crucial member of the care team. And I personally love working with them. I always learn from them, and they really are the experts in medications, medication counseling, guiding people through complex down titrations or medication changes, handling polypharmacy, looking for interaction. So, yeah, we are a huge proponent of pharmacists at Remo, and we include them in all of our care pods.
Wonderful. All right, next question is are there any predictive models to determine when hospice care is needed?
Yes, we
Ah, yeah,
oh, I'm
go ahead.
sorry.
No, 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 please.
Yeah, so we have a model that predicts hospice occurring in the next 30 days, 90 days, 1 year, whatever period of time. Uh, and that was utilized in part for some of the work that we have done for the SMART cohorts. So yes,
Very good.
Meredith, I don't know if you want to say something in addition
Yeah,
specific to your
just
case.
See, that
this is
struck a
a
chord with
huge.
Yeah.
Yeah. Sorry, this is just a huge area of interest of mine. Scott, would be wonderful to work on a project with you in the future on this. So yeah, there are, as Scott mentioned, predictive models for hospice. However, timely referral to hospice is actually remains a big problem in dementia care. Very high rates of disenrollment from hospice, and part of the reason that is that hospice care is often used as a stopgap for people being unable to access other in-home services, having limited options, and being referred to hospice perhaps early, before one of Scott's predictive models might suggest it in order to get some in-home services. And then that leads to disenrollment from hospice, burdensome transitions of care, and then decreasing the likelihood that hospice is actually involved with the person with dementia at the end of life, where it has the biggest benefit. So, um, part of the exciting part of the guide model is that we're actually trying to get upstream of hospice and provide the more comprehensive um, care that includes outpatient palliative principles before the need for hospice is there, to try to enable hospice to stay really where it should be, which is specialty care at the end of life and incorporating more holistic upstream palliative approaches in the outpatient setting to make sure that it's not just all one or the other and people can get some of the hospice type services and support without having to enroll in hospice if their prognosis doesn't allow it yet. So I think that the guide model will hopefully work hand in hand with the Medicare hospice benefit, and that will be providing holistic upstream care for patients with dementia and their families. And then be able to refer to hospice when it's appropriate using some of the predictive models that Scott mentioned.
Yeah, great. Such an important topic. And I saw
Yeah.
several people just coming in here to leave a comment saying, this is great. This is exactly what I need. I've been watching a parent for the last 10 years. And it's clearly something that we're dealing with, a lot of us personally. So really appreciate this topic. A couple other questions. Next is how current is the data that you get from the CMS Medicare database that your analysis is running on?
Yeah, so CMS issues uh, quarterly updates to most providers. We have access actually on a monthly basis, so our data can be as fresh as the prior month. And as you know, claims data itself, there's delays in submitting claims, so it's rarefied in the most recent month, but it takes about 3 months to get a full set of claims. So we typically analyze a quarter in arrears, but if you want the most recent data, it can be as late as, most recent as a month past.
Yeah, very good. Um, Next question here is, are you able to work with other organizations that have been given, that have been selected as guide participants?
Yeah, great question. So for any other organizations participating in the guide model, we can certainly work with you to help meet the care delivery requirements. One area we've seen significant need from other health systems has been around meeting the requirements around caregiver education and support. That's part of why we have our Learn and community platform. So yeah, we can certainly work with other organizations who are participating in Guide.
Great. Next question is, what is the financial impact of these dementia programs that have been run at academic medical centers?
Yeah, so for the from the studies that have been run, they've generated cost savings anywhere from $5,000 to $6,000 per patient per year. So these are in academic settings. So that's kind of the general estimate. I think one aspect of these studies is that there was individualization of care pathways, but not hugely. So I think there's also the opportunity to do more targeted interventions, identifying the highest risk people a priority that may also lead to additional cost savings.
Great. Uh, Next question here is, what types of organizations do REMO and HDAI work with?
I can
You want to
speak
go
on
first?
behalf of
Yeah.
yeah, HDI. So we took ACOs, accountable care organizations. They have a concern about understanding their whole network structure, and so we work with them to identify, optimize their networks, identify providers that are doing excellent work in certain areas and challenges in others. So that's a typical use for ACOs. We help them understand some of their predicted costs for future things. Their HCC, so they're reimbursed. Some of these are reimbursed in part by Medicare. So knowing the risk of their patients based on what are called hierarchical condition categories, we can provide them some information that lets them know what fraction of their patients have already received what we would predict to be the appropriate number of HCCs, that type of stuff. So that's one way. Healthcare systems, we work with trying to help them understand that, particularly for their patient management groups, the care management groups, they have scarce resources. There's only so many nurses that do excellent work, but you want to find those patients that are most critical to follow, and so we can provide them, a roster essentially of their patients sorted by the risk of bad outcomes, essentially, and they can then start targeting those individuals to follow up or to drill down into why it is that they're considered so risky. They generally might know, but we can quantify them and rank order them in a useful way for them. That's been a very significant improvement in the cognitive burden and the improvement in outcomes. And then there are collaborators. We've worked with a number of academic centers analyzing data for them using both the claims data that we have access to or other institutions that have their own data that we can then analyze for them so they can understand the performance outcomes of a given intervention, say, a new drug that came on the market versus what's commonly used prior to that, and we can let them know how that's performing, what the risks are, any sequela or any risk profile changes that have gone into that. And then um, similarly, we publish papers on comparing like the relative benefits of immunotherapy versus chemotherapy among lung patients or lung cancer patients, rather, as an example, or spine therapy, spine treatments. Is it better to do two interventions at the same time, or is it better to do them sequentially? So these are different areas. So any former research collaborators, healthcare systems, accountable care organizations.
Great. Very good. Well, that is all the time we have for today. And thanks for we had some little technical issues going on with our slides, but thank you for bearing with us. Dr. Bach, Dr. Greenwald, thank you so much for this presentation. This was meaningful, and there was a lot here. And as we close out here, wanted to encourage you all to head over to bbcexhibithall.com and check out the HDAI virtual exhibit booth. And there's a lot of great information you can read up about them and kind of educate yourself on what they're doing in the space. There's the resources and, of course, the ways to get in touch with them. And there's a lot of great resources there as well on bbcexhibithall.com in the archive library, which is also where this webinar is going to be housed. So you'll be able to find it there, but of course, we're also going to send it to you. You'll receive an email afterwards with a link to that into the slides. And then finally, if you would like to reach out to the HDAI team, or to connect with our speakers, the information is here on this final slide. Or feel free to reach out to me as well. I'm happy to facilitate an introduction if that's easier. But again, I want to thank you all so much for spending your afternoon with us. And thank you again, Dr. Bach, Dr. Greenwald, for a fantastic presentation. Hope you join us next time. Thank you so much. Bye-bye.
Thanks, Garrett.